Hello, I'm Isabel Rubio, and I'm going to be talking about the changing landscape of breast surgical oncology. These are my disclosures. So we are going to talk about improved localization and breast conservative surgeries, and also the continuous de-escalation of breast cancer surgery. We already know that breast cancer surgery is the default for early breast cancers, and there are enough evidence, even though it's retrospective, and this one is one of the meta-analyses that showed a survival advantage for women undergoing breast conservative surgery with adjuvant radiation therapy for early stage breast cancer compared to mastectomy. But we also have seen in the last years the development of new localization techniques for excising non-palpable and small cancers. And many of the wireless techniques have surpassed the wire localization, and those are intraoperative ultrasound guided surgery, radioactive or magnetic seeds, radar-based and radiofrequency-based techniques. Of course, the use of any of these devices will depend on the tumor and patient characteristics, but also on the availability of the resources at each center. The endpoints in the majority of the studies are margins, reoperations, and volume excise, but also it's important to look into the whole patient journey until they get to the surgery. The majority of them need training and a learning curve, and we usually use the intraoperative ultrasound-guided breast conservative surgery that has shown in multiple studies, prospective the majority, that we can achieve negative margins in a higher proportion than when using a wire localization, but also excising a lower volume of breast to get a better cosmetic outcomes. It is probably the technique that is easier on the patient pathway. So we have seen with all these new techniques that the local recurrence is declining because we have smaller and screen-detected cancers. We have less residual disease burden. Our surgeries are better planned. We use precise targeted excisions. We reduce the mastectomy rates by using oncoplastic breast conservative surgery, and we have standardized the margin pathology in many cases. The adjuvant radiation therapy will take care of the residual minimal burden disease, and the use of biologically targeted systemic therapy has also improved these local recurrences. The oncoplastic breast conservative surgery to reduce mastectomy has taken place using the chest wall perforated flaps. As you can see here, we can use flaps from different areas of the breast, and we can reduce the use of mastectomy, achieving a better cosmetic outcome. But also there has been a continuous de-escalation of breast and axillary cancer surgery. And this is the beginning of a fascinating story. So in the 70s, all the patients with a breast cancer diagnosis underwent an axillary lymph node dissection until the 90s, where the sentinel lymph node biopsy was developed, and it shows that there was no need to excise negative axillary lymph nodes, and the sentinel lymph node biopsy became the standard of axillary treatment in those early stage breast cancer patients because it showed to be safe, accurate for axillary staging. It was in the 2000 when we had randomized trials comparing those patients in the upfront surgery with a positive sentinel lymph node biopsy, whether they will benefit from an axillary lymph node dissection or not. And we can see here several randomized trials that has already almost 10 years of follow-up showing that the axillary recurrence in those patients with 1 or 2 positive sentinel lymph nodes, whether you do a completion axillary lymph node dissection or just a sentinel lymph node biopsy, the axillary recurrence were very low in all the cases. In some studies like the Amaros or the Otoazor, they were comparing axillary lymph node dissection with radiation therapy, but the most important achievement of these studies was that there was no difference in disease-free survival or overall survival in those patients with no axillary lymph node dissection. So this has been really changes in the standard in the practice that we do nowadays. Of course, mastectomy continues and it goes to the neoadjuvant setting where we have the first studies looking into the use of sentinel lymph node biopsy after neoadjuvant treatment on the NSIBP. And nowadays we have enough data to show that the sentinel lymph node biopsy in those clinically negative axilla who undergo neoadjuvant treatment is a safe and accurate way of staging the axilla with no need of axillary lymph node dissection. But what happened in those patients with a clinically positive axilla who undergo neoadjuvant treatment? We have enough data that shows that if there is an axillary pathologic complete response, the sentinel lymph node biopsy and the targeted axillary lymph node dissection is a safe procedure for staging the axilla. But recently in San Antonio, this last year, there was the first presentation of the AXANA study that it's a multicentric non-interventional prospective registry, so real-world data, looking into those patients with a clinically positive axilla, mainly CM1, with a pathologic complete axillary response after neoadjuvant treatment, and we were comparing the different axillary surgeries, axillary lymph node dissection, sentinel lymph node biopsy, targeted axillary dissection, or targeted lymph node biopsy, with a primary endpoint looking into axillary recurrence-free survival and also invasive breast cancer-specific disease-free survival. And the third endpoint looking into quality of life and arm morbidity. So the results of this trial that were presented in San Antonio was that when we compare axillary lymph node dissection in those patients with a clinically axillary pathologic complete response, the 3-year axillary recurrence-free survival were no difference between the different groups of axillary surgery, as you can see here. This is an important question because it means that in the real-world data, those patients won't benefit from a more morbidity axillary surgery. But what happened in those patients who do not achieve an axillary pathologic complete response? We only have retrospective data as far as now, and these are 2 studies just recently published in those patients with isolated tumor cells after neoadjuvant treatment. With a 5-year follow-up, they didn't find any significant differences whether the patient has an axillary lymph node dissection or not. And the recently published MicroNAC study looking into those patients with a micrometastasis after neoadjuvant treatment, and they have found that with a 3-year follow-up, the axillary recurrence were very low, and there was no difference in the patients who undergo sentinel lymph node biopsy and those who underwent an axillary lymph node dissection. In this study, those patients with triple negative without a radiation therapy and no axillary lymph node dissection has a significantly increased risk. But of course, we need to understand that these studies are retrospective, so not enough data to make any changes still in the practice on managing those patients with clinically positive axilla who undergo neoadjuvant treatment and still has residual disease in the axilla. But we can say that sentinel lymph node biopsy is one of the greatest success stories of contemporary surgical oncology. We have proven and we have enough evidence, prospective and retrospective, that it has proven to have long-term safety, long-term efficacy. It gives a better quality of life for breast cancer patients. It's the most accurate cancer staging, and of course, it reduces the cancer health burden. But the story continues, and the next step will be the omission of sentinel lymph node biopsy in the early stage breast cancer in the upfront surgery, but also we will have some data in the next years with the omission of sentinel lymph node biopsy in clinically negative axilla who undergo neoadjuvant treatment in very selective breast cancer patients with specific subtype tumors. Regarding those patients with upfront surgery, early stage breast cancer, we already have the publication from the SOUND and the INSEMA trial, and the BOC trial was presented the preliminary data on San Antonio last year. all of the 3 randomized studies look into those early stage breast cancer, CT1 and 2 and 0. All of them included axillary ultrasound as mandatory, invasive breast cancer, hormone receptor HER2 negative with breast conservative surgery, and whole breast irradiation. The studies, the 3 of them, has shown similar results. So distant disease-free survival and recurrence, axillary recurrence are very low, and there was no difference in the oncological outcomes between those patients who had a sentinel lymph node biopsy and those one who had an omission of sentinel lymph node biopsy. You can see that in the SOUND trial, overall survival at 5 years was very similar. Same thing with the INSEMA trial, no significant differences, even though in the local recurrence between the 3. Mainly the majority of the patients, as you can see here, median age was 60, 62, and 61 years old. So the majority of the patients were postmenopausal. One difference with the BOG trial was that in around 50 to 60% of the patients underwent endocrine therapy as adjuvant treatment, while in the other 2, the adjuvant treatment with endocrine was given to more than 90% of the patients. So the next step will be the omission of sentinel lymph node biopsy after neoadjuvant treatment. And we have mainly 3 studies, 2 of them already closed for accrual. The UBreast one from Europe, where we are looking into those patients with a clinically TN1 to TN3 and 0 HER2 positive and triple negative breast cancer who achieve a breast complete pathologic response. In those patients can have an omission of sentinel lymph node biopsy. We will look into the 3-year axillary recurrence as the first endpoint. It was closed for recruitment in December 2024, so we will have the first data on probably 2027, 2028. The ASLAN trial from South Korea, similar patients included with an endpoint of 5-year recurrence-free survival, also complete. And the optimistic, who is ongoing, very similar. In this one, they have included also omission of breast cancer surgery. And also we have the data from this phase 2 trial, just published last year in JAMA Oncology with a 5-year follow-up. Patients with triple negative and HER2 positive cancers who undergo neoadjuvant treatment. There were some indications for it. They included 50 patients, but what they have seen at 5-year follow-up is that the ipsilateral breast recurrence-free survival, it's 100%, so there has not been any recurrences in these patients. So this is a study that will guide us to more studies looking into the omission of breast surgery in this very selected population and excellent responders. So practice changing in 2025 has been omission of sentinel lymph node biopsy in postmenopausal breast cancer patients, clinically TN1 and 0M0, hormone receptor positive HER2 negative, and with the addition of the BOG trial that probably will be published next year, we have enough data to change the practice in this very early stage breast cancers. We are not doing any more axillary lymph node dissection in those patients with clinically positive axilla who had a pathologic complete response after neoadjuvant treatments, whether we use sentinel lymph node biopsy or the targeted axillary lymph node dissection that has shown the same results in the oncologic outcomes. Axillary lymph node dissection, in the majority of cases, we've seen that it doesn't improve oncologic outcomes and are really increase the morbidity and the quality of life of breast cancer patients. So we have understood the importance of the neoadjuvant and targeted therapies to increase the pathologic complete response, to help to de-escalate the breast and axillary surgery and to reduce morbidities from treatments. But also we have understood, and we are, more and more active listening to our patients, no decision about the patient without the patient, but still we can say that there are global disparities in access to care and technology, mainly in those lower and medium and lower income countries. So coming 2026-27, we will do in surgeries less invasive, more targeted and tailored to individual patient needs. Sentinel lymph node biopsy will become selective and not routine. We will omit sentinel lymph node biopsy and breast surgery in very selected patients after neoadjuvant treatment. In some cases, axillary surgical staging will be surpassed by genomic profiling to guide treatment decisions, and hopefully we will have more breast cancer patients being operated by specialized breast surgeons. And I think this is something that is really important to take into consideration. So thank you very much for your attention.